Good morning, everybody. I'm going to present a novel FujiLAM test to detect tuberculosis on the diagnostic yield of this test and the feasibility. Tuberculosis is the leading cause of death in people living with HIV, but diagnosis remains a challenge. The main diagnostic tests currently available in low resources settings have some limitations. A smear microscopy has a poor sensitivity and it requires a sputum sample. A gene expert has a good performance, but it also requires a sputum sample, which is sometimes difficult to produce by the patients, and it needs to be done in a laboratory. FujiLAM is a rapid test. It's a point-of-care test, so it does not require a laboratory. This is already an advantage. It uses urine instead of a sputum, which is also an advantage compared to a sputum-based test, but it has also a limited sensitivity. This test is currently available and is recommended by WHO for the diagnosis of tuberculosis. FujiLAM is a novel test. It's a point-of-care test, so it does not require a laboratory. It also uses urine, like FujiLAM. It produces results in 1 hour. It's still not commercialized. And preliminary data have shown a higher performance than the currently available FujiLAM, but it is also more complex to perform. As you can see in the diagram, this FujiLAM test requires several steps that needs to be timed. So briefly, you add urine to a tube, then you wait for 40 minutes. You take 2 drops of the mixture and you add it to the cartridge. You press one button. You wait another 10 minutes. You press another button, and then you can immediately read the result in a maximum time of 10 minutes, and the result is negative or positive. With this study, we aim to assess the diagnostic yield of the novel FujiLAM test in HIV-positive individuals, as well as the feasibility of implementing this test and the acceptability of the test by users and by patients. And for this, we are conducting a multicentric study in 4 outpatient sites in 4 countries: Uganda, Kenya, Mozambique, and South Africa. For the objectives on diagnostic yield, we are conducting a prospective study. It's including 2 groups of patients. Group 1 are patients HIV-positive adults with symptoms of tuberculosis, regardless of their CD4 count. Group 2 are patients with no symptoms of tuberculosis, but with advanced HIV disease. And patients are receiving a clinical exam, an FujiLAM and FujiLAM test in urine, an expert and culture in sputum, and a chest X-ray. For the feasibility objective, we are conducting a mixed method study that includes FujiLAM users, key informants, and patients. And we are doing direct observations, questionnaires to the FujiLAM users, group discussions with key informants, and individual interviews with test users and with patients. Let's now go to the results on the diagnostic yield. So up to now, from August 2020 to May 2021, we have included 1,117 patients. We are still including patients, so these results that we are presenting today are preliminary results. In the table, you can see the characteristics of the patients. First column is group 1, patients with symptoms of TB, regardless of their CD4. And you can see that the median CD4 in this group is high, around 550. And in group 2, these patients, they don't have any symptom of TB, but they are all with advanced HIV disease, so the CD4 count in this group is low, 140. In both groups, majority of the patients are on ARTs, and a few are seriously ill. And then when we look at the confirmed TB by expert or culture positive, we can see that in group 1, patients with symptoms, 9% have confirmed TB, and in group 2, patients with no symptoms and advanced disease, HIV disease, 4% have TB confirmed. Let's now look at the main results of the study. As I said, these are interim results. Recruitment is still ongoing. In the table, you can see the diagnostic yield of the novel FujiLAM test, and for comparison, the diagnostic yield of the currently available FujiLAM test in the same population. So let's look first at group 1, patients with symptoms of TB. FujiLAM detected 63% of the patients with confirmed TB by expert culture, and for comparison, ALERELAM 40% of them. If we now look at these results by CD4 count, we can see that there are important differences. In patients with low CD4 count, less than 350, FujiLAM detected 75% of the patients with confirmed TB, and for comparison, ALERELAM around 40–50%. And in patients with CD4 more than 350, FujiLAM detected 30% of the patients with confirmed TB, and ALERELAM 13%. And now finally, let's see group 2, patients with no symptoms of TB but advanced HIV disease. In patients with less than 200 CD4, FujiLAM detected almost half of the patients with TB-confirmed disease, and for comparisons, ALERELAM 7% of them. Let's now present results on feasibility and acceptability by Chennai. I think we don't have the sound of Chennai.
Can you hear me now?
Yes, it's fine.
Yes, I'm presenting feasibility results from all 4 sites. The test was performed by laboratory technicians, nurses, clinicians, and community health workers using already existing infrastructure. Training for users was performed in 2 to 4 hours, and the additional equipment required was urine collection bottles and timing devices. The chart presents user responses to questions about how they perceived the FujiLAM test as a whole. As we can see in the green colors, most users reported that the test was easy or very easy to perform. Despite the apparent ease of use, some users expressed that it would be difficult to integrate the test into their daily workload. This concern was linked to the test procedure time, particularly the 40 minutes incubation period that was mentioned earlier, and also to the multiple time steps. Users stated, however, that they used the 40 minutes incubation period to perform other activities like documentation. Apart from the workload concerns, a challenge faced was the test result readability. The user sometimes found it difficult to read the control line and the test line, and they found them faint, thus making it difficult to correctly interpret the final test result. The picture on the left shows an example of a cartridge with a very faint patient line. In some rare cases, invalid results were observed, that is, the control line was missing after a complete test procedure. This was reported twice after the test was dropped accidentally to the ground, and also reported in some instances when the urine was blood-stained or was cloudy in appearance. The picture on the right shows the cartridge with an invalid test result. The control line is missing there. On the question of who should perform the FujiLAM test, the majority of users, as illustrated by this quote, pronounced that the test could be performed by anybody, including lay health workers, emphasizing only that there should be appropriate training. Opinions differed as to where the FujiLAM test should be performed, in the laboratory or in the consultation rooms. One group, as illustrated by this quote, wanted the test to be performed in the laboratory, arguing that it was a complex test due to the many steps, plus the expected high workload for nurses and clinicians. The opposing group argued, however, as also illustrated by this quote, that it was a simple test and that the workload for nurses and clinicians was not likely to be high in real-life situations. In spite of these differences, there was agreement among all participants that the test was suitable to be implemented at point of care in outpatient settings. We will now hear from Pascal, who's going to talk a little bit about the patient experiences. Thank you.
Hi, thank you, Chennai. I can't see the slides. Thank you. So for our qualitative descriptive assessment of patients' acceptability, we identified 3 domains. So firstly, participant perceptions of urine sampling and urine-based TB testing were mostly positive. Urine is considered a waste, available, easy, and quick to produce even when not feeling the urge. Urine sampling is also preferred and perceived as more convenient than sputum provision, which may necessitate often painful and messy induction. As a patient from Mozambique stated, I'd rather collect urine because, as I said, you may not be coughing and producing sputum is not easy. Maybe you have to induce it. Whereas with urine, that procedure is not necessary. Overwhelmingly, participants requested same-day results and were prepared to wait for up to 3 hours for their diagnosis, citing the emotional, physical, and financial burdens of having to return to collect their results. As expressed by a patient from South Africa, it must be the same day rather than to come back the next day because of money for transport and time, and we are sick. It is better to just go to the hospital and be prepared to wait. Secondly, facilitators of urine provisions, such as toilet perceived privacy, proximity, and cleanliness, influence participants' experience and for some willingness to sample urine. As a patient from Uganda explained, if the toilet had been dirty, the urine would not have come out, because when you go to a messy place, you know that even what you have to do cannot happen. Other strategies, such as having a dedicated sampling environment for TB presumptive patients and supplying envelopes to return the samples, were requested to ensure patients' privacy and reduce TB stigma. As shared by a patient from South Africa, if you do not like people to see what you are doing, you go to the toilet, take urine, and hide it. While with sputum, a person can hear you and feel disgusted. Lastly, motivational factors such as having concerns about one's health, especially when experiencing symptoms, and the trust in and quality of communication with the medical team appear to encourage participants to engage in urine sampling and accept urine-based TB results. As a patient from Uganda asserted, the important thing for me is to restore my health. I met health workers who were very supportive. I can never question what the health workers tell me. And now for the study's conclusions.
Diagnostic yield, we have seen that this test detects a considerable proportion of the symptomatic and the asymptomatic patients with confirmed TB and low CD4. It detects lower proportions of confirmed TB in less immunosuppressed and have a higher diagnostic yield than the currently available and already useful and recommended FujiLAM test. Regarding the feasibility and the acceptability, we have seen that the implementation of this test as a point of care in outpatient settings is feasible. The test is easy to perform by a variety of health workers, including community health workers. Urine sampling is well accepted by patients and preferred to sputum. And however, the test requires time attention. Overall, up to now, with the results that we are seeing that FujiLAM is a useful diagnostic tool that can be implemented as a point-of-care test in outpatient settings, and I think this test represents a step forward for TB diagnosis in HIV patients. I would like to acknowledge the patients that are participating in this study, our MSF and Epicenter colleagues who are working in the study and supporting it, the Ministry of Health from the countries involved, the FIND who is donating the test, and the founders of the study, the ANRS and Médecins Sans Frontières. Thanks for your attention.